everyone, I'm Dr. Radhika PM, Associate Professor from Ramaya Medical College. Today we'll be learning about the applied anatomy of spaces of hand. Disclaimer: all images used in this presentation are from the textbook of anatomy, various internet sources. The images are used for teaching learning activities only. The video is done to help the undergraduate understand the clinical anatomy. I acknowledge the ownership of the images and give complete credit to them. Coming to the specific learning objective, the student should be able to describe the clinical and surgical anatomy of spaces of hand. What are facial spaces of hand? They are the potential spaces filled with the loose connective tissue. It is of surgical importance because they become distended with pus when it gets infected. Their boundaries are important clinically because they may limit the spread of the infection in the palm. Coming to the palmar spaces, so we have the thenar space, midpalmar space, the web space and the pulp space. Distally, the thenar and the midpalmar space are continuous with the appropriate lumbrical canals. Coming to the palmar space, so before knowing about the spaces, this is the section of the hand where you can see this is the radial side and this is the ulnar side. Here you can see the thenar muscles and these are the hypothenar muscle, and here you can see the flexor digitorum superficialis. These four are the flexor digitorum superficialis and these four are flexor digitorum profundus tendons. Now underneath that you can see this is the thenar space and this is the mid-palmar space. Here you can see this is the adductor pollicis and these are the introssei which are present between the metacarpal bones. So here you can see the extent of the thenar space and here you can see the extent of the mid-palmar space, and here you can see this is the thenar space and this is the mid-palmar space. Coming to the first case history, a 36-year-old woman presents with the pain and swelling at the radial side of the palm. She recalls squeezing an infected pustule near a thumb 4 days ago. Since then, there was a swelling on the lateral palm which has increased and she has difficulty in opposing the thumb and also complains of throbbing pain. There is no numbness reported. There is a swelling and tenderness in the thenar eminence and pain is induced by the extension of the thumb and the index finger. Now the ultrasound was done which showed the fluid collected in the thenar space which was superficial to the adductor pollicis. Now with this clinical case history and the physical examination and the ultrasound, what is the diagnosis? So the diagnosis is the thenar space abscess. So you know the location now of the thenar space abscess. So we will be learning about the boundaries of the thenar space. So boundaries, in front it is related to the thenar muscles. Here you can see the thenar muscles which includes the abductor pollicis brevis, flexor pollicis brevis and opensis. Along with that the first and the second lumbrical. Behind it is related to the adductor pollicis and to the first introssei. Now laterally, this is the lateral boundary. It is related to the lateral palmar septum and medially it is related to the intermediate palmar septum. This is the intermediate palmar septum. So these are from the palmar aponeurosis which is dividing into compartments. So these are the boundaries. Proximally, it extends up till it is limited till the floor of the carpal tunnels, and distally it extends up to the lumbricals. Now, infection reaches the infected from the radial bursa or from the synovial sheath of the index finger, and the pus is usually drained by the incision in the first web space. Now, coming to the second case, a 42-year-old carpenter presents with the severe pain and swelling in the central palm for 3 days. The patient reports accidentally pricking his left palm with a wooden splinter while working 5 days ago. He has developed progressively worsening pain and a diffuse swelling. He has difficulty in flexing the middle and the ring fingers. The pain increases significantly when he tries to grip the objects. He reports low-grade fever and malaise. On examination, there was a swelling in the central palmar region with the loss of palmar concavity. There was tenderness along the third and the fourth lumbrical canals, and the pain was on passive extension of the middle and ring fingers. There was severe pain. There was local warmth, skin is tense but not erythematous. So, what is the diagnosis? So it is a case of mid-palmar space in abscess. So there's an abscess. You can see from the clinical feature and from the examination the location of the mid-palmar space. Coming to the boundaries of the mid-palmar space, it is bounded anteriorly by the long flexor tendons of middle, ring and little finger along with the lumbricals, that is the third and the fourth lumbrical, and posteriorly it is related to the third, fourth and fifth metacarpals and the introche which is present between it. So it is related posteriorly to the introche and the third, fourth and fifth metacarpal bones. Medially, it is related to the medial palmar septum, and laterally it is related to the intermediate fibrous septum. Now this interfibrous septum divides the mid-palmar space from the thenar space. So here you can see this is the thenar space and this is the mid-palmar space. Now coming to the distal communication, distally this is the mid-palmar space. It communicates with the lumbricals from the third to fifth digit. So third, fourth and fifth it communicates with it, and proximally sometimes with the carpal tunnel, especially via the flexor tendon sheath. And from here the infection sometimes may spread to the space of Parona. The ulnar bursa is considered as the inlet for the infection, whereas the lumbrical canal is considered as the outlet of the infection. So pus usually it is drained by using medial two web spaces. So these two web spaces, when you give an incision, you can drain from the mid-palmar space. So that is the surgical importance. For thenar abscess, we usually put an incision along the first web space, whereas the medial two web space is used for the mid-palmar space infection. Now coming to the third case history. So here you can see a 50-year-old diabetic man presents with the painful swelling between the index and the middle finger. He noticed a small ruptured blister that had ruptured 1 week earlier. He had severe pain with fingers held apart. You can see that V sign because of the diverging fingers. He reports fever and inability to approximate the two digits. So he is not able to approximate the two digits, and you will see the classical V sign because of the infection at this area. So there is a fusiform swelling of the web space extending dorsally. There is a pitting edema. Tenderness is present on both palmar and dorsal aspect. There is a The passive movements are extremely painful, and ultrasound or MRI shows the collection of fluid in the first web space. So this is a case of collar button abscess of web space, also called as palmar dorsal hourglass abscess. So what are these web spaces? It is the potential space which is surrounding the tendons of each lumbrical, normally filled with the connective tissue. There are three in numbers. They lie between the index, middle ring and little finger, and proximally it is continuous with the palmar spaces. So the first one is usually continuous with the thenar um, space, and the remaining are continuous with the hypothenar space. Next, coming to the case 4, a 28-year-old man with the flexor tenosynovitis now has swelling extending into the distal forearm. He had pain along the little finger tendon sheath. Now, within 48 hours, the swelling had extended to the proximally into the forearm with severe pain, and on examination there was a swelling and tenderness in the distal forearm between the pronator quadratus and flexor tendon. The fingers held in the slight flexion position. This is showing a different finger, but this is the position where how it is held. It is slightly in flexion, and pain on passive extension. If you forcefully, if you extend the finger, the person will complain of pain, and this is called as the Kennevel sign. So the diagnosis is, so there is an infection in the little finger which has spread to the forearm. So it is the Parona space infection which is secondary to the ulnar bursa spread. Now coming to the boundaries of the Parona space, it is a deep forearm space which is located between the flexor tendons and pronator quadratus. So coming to the boundaries, so this is the section of forearm. Here you can see the radius and ulna, and here you can see the flexor tendon, and this is the pronator quadratus. So the space between this is the space of Parona. So anteriorly it is related to the flexor digitorum superficialis, flexor digitorum profundus, and also to the flexor pollicis longus. Posteriorly it is related to the pronator quadratus and the interosseous membrane. Proximally, it is continuous with the mid forearm deep fascia, and distally it communicates with the ulnar bursa and the radial bursa. So, infection from the thumb is spread through the radial bursa to the space of forearm. The same way, from the little finger through the ulnar bursa, it spreads into the space of Parona. So the space of Parona is a common meeting point for the infection from the ulnar bursa, from the radial bursa, and also from the collar button abscess from the web space. Now, flexor tenosynovitis of any digit, especially the thumb and the little finger, will lead to a horseshoe abscess pattern. That is, thumb, palm, and the little finger is infected. So, this three together it appears like a horseshoe. So, that abscess is called as the horseshoe abscess. What is this pyogenic flexor tenosynovitis? It is a closed space infection of the flexor tendon sheath, and it usually results from the penetrating trauma or hematogenous spread. But if it is of little finger or of the thumb, usually there is a spread of infection to the space of Parona. That is what we saw in the previous case. Now coming to the fifth case, a 34-year-old tailor presents with the rapid worsening pain at the fingertip. 4 days earlier, she pricked her right middle finger with the sewing needle. She cleaned the area herself and continued working. Within 24 hours, she developed an increasing throbbing pain, which was worse at night, and there's a swelling of the finger pad. There is tenderness on touch and difficulty in holding objects. She feels tightness inside the fingertip. Now, on examination, there is a diffuse swelling of the olar pad. The skin appears tense, shiny, warm. There is a tenderness, throbbing pain, and also the person is, the pain increases by the passive extension at the distal interphalangeal joint. So, what is a diagnosis? So, there's an infection to the pulp area. So, this is called as Whitlow or Phelan. So, pulp space is a space which intervenes between the palmar skin and the distal phalanges. So, here you can see numerous fibrous septa are connecting from the skin to the distal phalanx, dividing this pulp space into a number of lobules. This pulse space is supplied by the terminal branch of the digital artery, which supplies the diaphysis of the terminal phalanx. But the epiphysis of the distal phalanx receives its supply proximal to the pulse space. Now, this is of surgical importance because if there's an infection in the pulse space, and if it is for a long time, it can result in the avascular necrosis of the diaphysis. But the epiphysis of this bone is saved because its arterial supply is just proximal to the pulse space. So here you can see this is the artery which doesn't enter the pulse space, so the epiphysis gets its nutrition, but the diaphysis there is a avascular necrosis because of the involvement. And usually they give an incision longitudinally so that they open all the locules or lobules. Now, coming to the seventh case history, a 29-year-old woman presents with an acute onset of pain and redness and swelling around the lateral nail fold. 3 days ago, she had pulled a hangnail while she was doing a housework. Within 24 hours, she developed increased redness and swelling, and there was a severe throbbing pain. Small yellowish collection of pus near the nail margin was seen. So the clinical diagnosis here is paronychia, which is an infection along the lateral nail fold. It follows any trauma of the nail bed. So for this, the surgery, a small incision is done, or they elevate the nail fold using the blunt dissector. This allows the pus to drain. If the pus is deep, a small stab incision along the nail fold may be required. So to summarize, we have learnt about the different palmar spaces, what is the presentation of infection in these palmar spaces and where to what extent can it spread, and what are the surgical incisions which are given for different types of palmar space infections. Thank you.